Right, hello everybody, good afternoon. I think we're going to start with the grand rounds, a little bit of introduction and some housekeeping while people are logging in and sorting out the registration details after such a long time away. So welcome back to grand rounds. I hope everyone had a good summer break and have managed to get some leave in or got away out of London if possible, or even abroad. But if you did that, maybe you're not allowed to come back. Remember that we can see the previous grand rounds, which are all being recorded and then edited and put up on gold, so you can see it by the internal website if you'd like, or welcome to follow it and share it with your colleagues and friends via the GLA Learning Academy YouTube channel. And that's all those videos are free to be seen there. And we've got about 300 or 400 views on YouTube on some of the grand rounds we've had in the past. So they're turning out to be quite popular for people around the country and around the world. So like before the grand rounds, what we're saying is that the colleges are saying you can accredit yourself for 45 minutes of CPD plus 50 minutes of reflection if you like, and if you need a certificate for your appraisal or your college, you can get a certificate of attendance if you fill out the feedback form via the SurveyMonkey link, which comes up at the end of the grand rounds. So what I'm going to do is I'm going to hand over to Sherry Lou, who's our fellow in PGME, Medical Education Fellow, and she's going to introduce the team who are going to present the grand rounds today.
Hello everyone, so welcome for the palliative care team come to present with us on the topic of has COVID-19 changed death and dying. So I would like to introduce the first speaker, Kerr-Elliot, who is a CNS in palliative care team and NIHR fellow, clinical fellow for Orchard Project. Welcome, Tara.
Thanks very much, Sherry. Yeah, so today we're going to be thinking about how COVID has impacted death and dying within the context of our work in children's palliative care. It's maybe a slightly different style of grand round. It's something we did via a webinar earlier in the summer, which we've been asked to repeat here for a wider audience. I'm going to set the scene before we hear from a number of other members of the palliative care team, sharing their own reflections on how COVID has impacted their individual areas of work. But first, if you possibly can, think back to a world before COVID-19. Death and dying continued to be a taboo subject. Something which is so universal, which affects us all, is something that so many of us still try to put in a box, compartmentalized by the collective. And even working within palliative care, I think we have done this. We sometimes try to pretend that it affects certain other groups of people, that we hope that we can exclude ourselves from. We give labels to the dying, palliative patients, the bereaved, even though we will all inevitably be members of these groups at some point. For the majority of time, many of us do all that we can to separate ourselves from them. But then came COVID, and as the pandemic crept closer towards us from China, Italy, Spain, we were faced with images in the media of people dying, of mass graves. And so then here it is, suddenly these topics related to death and dying, care planning, DNARs, dying at home, they were being discussed widely on the news, on phone-ins, on social media, on street corners. Can you remember the first UK death when that was reported? You might remember some details. I remember it was a lady in her 70s in Reading. But as the numbers rose, of course, the details got lost. But behind each number is, of course, a person, a birth, a life lived, a story, and family and friends left behind. COVID has forced death out of any box that we might have tried to use to contain it. Boundaries between work and home, personal and professional, have become blurred in this context. And COVID-19 is an illness like no other in terms of our clinical practice. It is not something which just affects our patients. It may affect their families, our friends, our colleagues, and ourselves. Some of us have been forced into the role of patient. And of course, tragically, some of our colleagues have died. Personally, I had to step away from safety nets I had created for myself as I volunteered to be redeployed and spent several weeks working with the pandemic multi-agency response team. Faced with the Metropolitan Police Force, we attended sudden, unexpected COVID-related deaths. One of the roles was verifying deaths out of hospital, an example of practical changes brought in because of COVID. There was a recognition that because of the expected numbers, we needed to train others to be able to do this. At one point, we were training newly qualified dentists to do this role. Death certification and registration went online, a process which many families have reported as helpful. And the phrase that I uttered most during that time was, "But I'm a children's nurse." Having never nursed adults, I felt totally unprepared for this work. But like others, I was quickly reminded that death and dying is bigger than the box of children's palliative care that I had personally tried to contain it in. In dire circumstances, wearing hazmat suits and full PPE, my toolbox of helpful phrases and solutions that I had developed over the years was suddenly useless. And I had to resort to the most basic ways of showing compassion, human to human, kindness and presence. Indeed, although I have worked exclusively in children's palliative care for nearly 20 years, it took the pandemic to help me to really understand that true compassion often isn't about saying or doing. It's about resisting the urge to run away from other people's pain. But to be truly present with those who are suffering invariably costs us. And so caring for ourselves cannot be seen as an optional extra and is important now as it's ever been. Palliative care, care for the dying, whether children or adults, can no longer be seen as a job confined to specialists. COVID-19 has reminded us it's everybody's business, and it is something we want inevitably be unable to avoid. The aim for today is not to simply report negatives or dwell on depressing statistics, but instead to consider how COVID has impacted children's palliative care. And we will hear how, despite the fact that thankfully children themselves have rarely become very sick or died from COVID, in children's palliative care we have still had to respond and adapt to many of the challenges it has brought. Some of these things may be things you've heard lots about, others may come as a surprise to you as we discuss some of the more hidden aspects of death and dying during COVID. As we present, we invite you to consider whether COVID-19, whilst has robbed us of so much, may also have presented us with new opportunities to improve on the old way of doing things, to communicate more openly maybe, or to create new ways of supporting those facing death, grief, or loss. And we also want to reflect on the creativity and resilience of our workforce in overcoming obstacles, including how to look after ourselves, enabling us to continue providing this high quality individualised palliative end-of-life and bereavement support. So I'd now like to introduce Dr. Zoe Berger, who's a consultant clinical psychologist working with children across a variety of medical teams at GOSH, all who have life-limiting or life-threatening conditions.
Thank you, Tara. So as Tara said, luckily the focus hasn't been on children dying in the numbers that we might have initially been concerned about. But of course, during the pandemic, children have continued to receive life-limiting and life-threatening diagnoses, and children with palliative conditions have died. And as psychologists supporting families and staff teams during this time, one of the most notable impacts has been the one carer policy. So only being allowed one parent on the ward at any one time. And so I'm going to say something about that. Most of the people I've spoken to have a view about the policy and some experience of the impact that it had on families. And recently we took the dilemma to the ethics committee, really just to have a space to reflect on the often hidden psychological risk to families that came with this enforced separation. So it feels really important to say that I witnessed a number of occasions when teams and wards bent over backwards and were able to change or flex the rules at the very end of the child's life. So bringing parents together to say goodbye and to care for their dying child. But it was much harder and considerably more burdensome for those families whose children were incredibly sick but not yet actively dying. So I guess what I mean is in that period of time when there may have still been a number of attempts at active treatment, that there was still hope held by the team and the family that the child might get better. And parents have talked with us about the emotional impact of not being able to be together in that period of time, how hard it was not to be together as a family, not to be able to make memories, or for broader family members, not to be able to see or spend time with or support the child that's sick and in hospital. And for some of the neonates who spent their entire life in hospital, that child never got to meet their siblings or their grandparents. There were perhaps no family photos, something that's usually such a normal rite of passage for a new baby into a family. And whilst most of the parents that we spoke to could understand the reason why this rule was in place, the emotional impact of not being able to be together in the short time they had remaining with their child has really been profound. We saw more acute levels of distress, heightened feelings of guilt, of anger, of loss, and kind of personal conflict. But the impact wasn't really limited just to the end of life or in the last few weeks. We saw a considerable psychological impact of parents hearing a diagnosis, waiting for or receiving scan results, taking children for invasive procedures, or listening to an ongoing treatment plan on their own, as well as the impact of being separated from their other children for periods of time. There's this real sense, I guess, that they were holding the burden of responsibility for their sick child themselves. And one parent described it as walking the corridors alone without the physical presence of the person they need or want the most at the time of greatest need. And it was much harder as psychologists to help these parents to engage with or stay connected to their usual ways of coping. We observed higher levels of exhaustion and emotional lability in parents, and they were less able to use their support networks to mobilise their own self-care. So even at a basic level, to be able to take regular breaks from the ward or the hospital, to be able to engage in physical activity, to even get a regular meal. And all of this then had a knock-on impact just on how able they felt to be able to cope with the often complex decision-making and care that they were needing to deliver to their child. And parents have said that they felt less able to look back and remember those last few weeks in the way that they might have liked. And this was also connected to some extent to families being unable to use the mortuary in our usual ways. So being able to help support families to say goodbye was being disrupted. And I know Rachel is going to say more about that. And it hasn't just been the impact on families. We also saw an impact on our staff teams. And the lack of usual family support meant that we witnessed bedside nurses, clinical nurse specialists, members of the team taking on more of the emotional care. So stepping up into this kind of pseudo partner supportive role. And we've often considered those staff groups to be key in providing emotional support to families, but the burden on these individuals was often greater, especially for those moving towards the end of life. But one of the positive things that's come out of this challenge for us as psychologists has been the increased number of requests that we've had to run psychological debriefs for clinical teams. And as a group of psychologists working within the broad remit of palliative care for years, we've often run debriefs, but we've really seen an increase in the requests for this kind of specific support. And I think the widespread use of Zoom has meant that we've really been able to increase the reach and access of these to staff members that might not otherwise have been able to attend. We've been involved in a number of discussions nationally about the relative pros and cons of delivering debriefs by Zoom and ways to ensure psychological safety. But for the most part, we've seen it to be helpful and think it's a good development. We've also observed not just an increase in the request for debriefs, but this real shift in the nature of the conversations that we're having with people. So people who are joining these debriefs feeling more able and willing to bring the personal and professional dilemmas they experience in this work to the meeting. So this overlap between home and work and the struggle that comes with the lack of boundaries in our work that we do. And both Tara's mentioning it, and I think Finn's going to talk about it in a few minutes. So that's my bit. I'd really like to introduce Dorothy, who's been a healthcare chaplain for 20 years, most of which it's been at GOSH. And the main focus of her work is with children and families in our cardiac and respiratory wards. And she is the lead for end of life in the chaplaincy and spiritual care team.
Thank you very much, Zoe, and good to see everybody here today. So thinking about how death and dying has been changed in COVID, I come right back to my own team, the chaplaincy team. And the key thing we're about, and which we always teach students about who are on placement with us, is presence. Chaplaincy at its heart is about turning up, about being there in the highs and the lows and the humdrum in between. And from the get-go, as soon as lockdown was announced, we had an issue in that almost everyone in our team, for different reasons, had to shield at home. So how could we be a presence? Most of our volunteers, similarly, were also stood down. So our usual ways of working were challenged, and we had to rethink quickly and creatively. What were the new ways of being present that we could employ so that our families and patients and the staff we support could have presence if that's what they wanted? How could we be there when we physically couldn't we be there? We had a first on call and a second on call system so that hopefully there would be someone who could turn up in person. But there were times where that couldn't happen. And so the support we offered had to be remote. We quickly prepared a set of resources from different faiths and none, which were available for end-of-life support in particular, so that if the person on call couldn't be physically present, then they, with the support of healthcare professionals on the wards and units, could somehow facilitate an end-of-life ritual, many of which, as you will know, are quite physical acts in themselves. So we needed that partnership, and we were so grateful to our colleagues who stood in that gap. And of course, another part of our core work is funerals. It was especially hard for families whose child died in this time, as Zoe has talked about, as the rules around funerals were really strict and inflexible. And it meant that extended families really couldn't gather, friends couldn't be there. And some families found really creative ways for others to mourn with them, to stand with them. But some of the toughest moments were seeing a family gathered at a graveside who couldn't hug one another. There were different ways of mourning, online ways, families whose friends lined the route, etc. And what we've heard from families is that some will want to have a memorial service later in the year, or even next year now, it looks like, when more people can gather. But a few months on, we're hearing from those same families who at the time thought that would be what they'd want to do, that they're now feeling they can't really face going back to that rawest point of grief again. I guess time will tell how people will memorialise together. And like our colleagues in psychology and bereavement, we've found that we've been busier than ever with just ongoing pastoral care because of the one-parent policy that was in place, understandably, for so long. And those of us working on site found that when we did go and see families, they just didn't want to let us go. They needed someone to stand in the place and in a sense represent all those who might have been there but couldn't. And people were coming to our department regularly, just seeking a friendly face, someone to talk to. And that leads me on to the idea of sacred spaces. All of us need them. Some of us will find our sacred space on Hampstead Heath or while we're out running, and some will find that to be in a religious building. In the hospital, we have the prayer room, the chapel, the Shabbat room, and we had to work really hard with the trust to make sure we could keep these spaces open when the government advice was that places of worship should be closed. Some trusts did close their sacred spaces, but we felt very strongly that with risk assessment and social distancing protocols in place, we had to do all that we could to keep an open door, because staff and parents particularly needed a place to be, a sacred space in a sense, just a place to find peace, a non-clinical space to find some quiet, to reflect or to pray when so many other options were closed to them. And of course, there were those amongst us who were bereaved of a family member or a friend who couldn't attend a funeral and wanted a time and a space and support, perhaps, to remember the person who died. Each year as a chaplaincy team, we're privileged to welcome about 400 people to our annual memorial service, which happens every April. And of course, that had to be cancelled along with all other gathered events. In response, we offered a very simple online offering of an act of remembrance that families could do in their own time and their own home. And what we've learned through that is that online communities of support can work with a little bit of creativity and a lot of care. And we've learned that not everything has to be a physical gathering for it to have meaning and impact. And that's certainly something that we will take forward as we move out of the COVID year. And of course, as others have mentioned, staff support was really, really important. We talked a lot at the time about the hit being not with the children who were getting ill of COVID, but with our colleagues. And sadly, as we know, 3 of our colleagues died. And at such times we're reminded that we are an extended family in a place like Great Ormond Street, and that every member of that family matters. And so we needed time, permission, space to lament, to grieve. It was all the more stressful as some of us were dealing with that balance of hearing terrible news about colleagues and still having to get on the tube in the morning and come and do our shift. And many of us were so brokenhearted by that. Some of us who are really good at separating the professional and the personal just found that that boundary was challenged as some of our own were so wounded by COVID. And we've been part of the wellbeing offer, along with our colleagues in psychology and bereavement, to support staff who've been affected. Back to my point about a sacred space, we've all needed time and space, albeit in different ways, to cope with all that we've seen and felt and experienced. I'd like to introduce to you Bhumik Patel, who's a specialist paediatric palliative care pharmacist in the palliative care team. Bhumik.
Thank you, Dorothy, for the introduction and for your presentation. So I'm just going to, changing tack slightly, just move on to kind of medicines management and how medicines were impacted in end-of-life care and how we managed to maintain services, but also how we actually, for the first time in a long time as paediatric professionals, helped develop adult services and help them cope with what they were expecting to be a very, very difficult time. As a bit of background, so the COVID-19 pandemic forced huge strategic and structural change on the NHS, and the NHS, as we know, doesn't like being forced into change. There were dual fears, one of increasing demand for beds and how they would be staffed in hospital led to plans to redeploy community-based staff back into hospitals, but also with more patients having enforced DNRs in community, how would you then care for end-of-life care patients at home without the community resources? And this led to kind of a huge strategic conundrum for end-of-life care services in that, can patients still have a choice for place of care at end of life? Is it still viable? And if that choice is still viable, how can you protect that choice without compromising the quality of care they get or impacting on the quality of life that they have? The problem within the adult services was that much of end-of-life care within adults utilizes parenteral and invasive therapies for symptom management and comfort support at end of life. So, for example, they rely quite heavily on these continuous infusions for background symptom management, as well as using parenteral bolus medication to kind of deliver breakthrough symptom management. Much of these parenteral boluses are delivered by district nurses or palliative care community nurses, many of whom were potentially to be redeployed back into hospital settings. So how can you effectively symptom manage patients through this period of time where you've got less staff to care for these patients, but more patients needing care for? In addition, technology. Most teams have very limited access to the pumps required. So where you've got more patients needing technology to deliver care, how do you then manage those patients? So, and this is where the adults turn to pediatrics. In pediatrics, we're quite au fait with limited resources and making the most of what we can with the resources that we have. In addition to that, we know our children don't like parenteral invasive therapies, and that could be quite a psychological derogatory part for them. So we, in pediatric practice, try and utilize other methods of symptom management, maintain oral and non-invasive routes far longer than our adult colleagues would ever do. And because of this, we were able to teach the adults something about delivering symptom management care to these patients without using parenteral invasive techniques. We shared with them knowledge of our alternative routes of administration, so the use of sublingual medication, buccal medication, and intranasal, and even novel topical routes of administration. And this then meant that there was a less reliance on using technology, as well as less reliance on what would happen if we had less workforce to help deliver symptom management and end-of-life care in patients at home. In addition to that, we were able to share our symptom management plans. So with adult palliative care, it tends to very much be at the end of life. With COVID, the changing dynamic was that they were seeing more and more patients with progressive symptomology that was very, very frightening, particularly breathlessness and dyspnea, which is a common symptom we manage within pediatric palliative care. we were able to provide our symptom management plans for these conditions to our adult colleagues. And from that, they were able to devise and develop standardized template plans for how they would manage adult end-of-life care in the community and at home without the reliance on hospital beds or parenteral medication. We were able to do these based on our knowledge of disease types, knowledge from clinical practice, as well as from research about common symptoms that we see, our knowledge of the decades of end-of-life care in children, and the fact that we were able to adapt quite nicely to the patients we see and the conditions that we see, and adapt to limitations in medication access. In terms of symptom management plans, we were able to share with our adult colleagues the fact that we are able to tailor our symptom management needs to our patients, and that was key to how we deliver end-of-life care to children. And that's a key thing that the adults took from us in terms of managing COVID, because it's such a unique end-of-life pathway that they're not used to seeing. We were able to share kind of evidence for the novel routes and evidence based in clinical practice, as well as evidence based in research and literature. I'm going to leave it at that and move forward to Rachel Cooke, who's the head of bereavement services. Thank you.
Hi. What we noticed, the changes that COVID-19 had an impact on bereavement services has been discussed by Dorothy and Tara. But one of the biggest increases that we noticed in May was the deaths in the trust. We'd actually doubled our numbers, which was unprecedented for us. And so the impact that that has on as a trust, both on the wards and ICU, in the mortuary, bereavement teams and all the support teams, was phenomenal. And the wellbeing structure that was put in place was really important to support the staff in supporting families. I think we all recognise just how hard it was end of life for children dying within hospital. And because of the increase and very little space within the mortuary, it was felt that we couldn't assist with viewings down in the mortuary. And this had an impact on our families. Some families agreed that they could go and view their children at the funeral directors and were okay with that, while others, especially coroner's cases, felt bereft that they couldn't visit. And this had an impact as well on the nurses who were caring for those families. But I just want to bring and highlight just the wonderful team we have in the mortuary. I've been blown away by the wonderful support that they've given both to the children in their care. What has been highlighted to me was in 1 week, we had 4 suicidal deaths that came in. We've had the murders that have been very public in the forensic cases, that have been very public in the media. Because of adult mortuaries needing to be used elsewhere within London for the adult cases of COVID, and while we didn't see actual COVID deaths of children, we saw an increase within the mortuary. And so that team didn't increase in numbers to deal with all that they saw. For example, they did 6 postmortems on one day. They might have a child where they have to remove, for example, the bones to be sent off for various areas, but then they crafted out of plastic beads bones so that that child could be viewed. And just the sensitivity and the way that they care for the children was absolutely blew me away as a bereavement when I went down to support the team. So they went above and beyond measure in looking after the children that came into their care. I think often we forget just what the impact that the mortuary team have upon them as personally. Dealing with the increase in suicide, we both network with all the children's hospitals through bereavement services, and all the children's hospitals noticed an increase in teenage suicide. And again, this has an impact. I'm sure there will be reports later that come out. But I think we have to recognise the impact of bereavement on our families. I think some positive note is that the online, which I've been hoping to be able to deliver online bereavement support, was enabled very quickly, and we were able to support families. But something that had been evident in supporting the families, the extended family members like grandparents, aunts, uncles, that couldn't attend the funeral or have any to see the child when they were dying. has had a large impact, and so needing a lot of support. So our bereavement referrals into the bereavement services has increased. I'm sure chaplaincy has experienced the same, and psychology. So while there has been some benefits like the online registration for families where they don't have to rock up to the registry office, they can do that with a book session online. That's been a benefit, and I hope that's something that we can keep going forward. I just think that also we will probably review the viewings. The viewings can be done now in the mortuary, but how we take care of one another and being present in, like Dorothy mentioned, the sacred places of just being with each other, being kind as a trust and support. I think that's that we are one #1team. So I think what the other impacts that have happened for families, like I mentioned, was funerals and extended family members, and bereavement support will be increased online. I just want to thank at this opportunity for all those that have involved, that have supported like a virtual bereavement team. I am grateful to one and all. Thank you. I'd like to introduce you now to Finn Craig, our palliative care consultant.
Thanks, Rachel. So my job at the moment is just really to sum up all the things that we've been talking about today. I think one of the things that's really clear is that COVID has forced us all to reevaluate how we deliver high quality end of life care. And one of the things that has come across for me from all the reflections that we've heard today is the importance of being present. I think virtually everyone has mentioned being present at least once in their reflections. I think it's important to sort of be aware that when someone is dying or has died, we can't always relieve all the suffering. We often as professionals think that we should be able to think that there's another drug. We want to get rid of the suffering of the child, of the family, of our colleagues. But we can't always get rid of it. But one thing we can do is be present, and we can be present emotionally and physically. Being present enables the family and our colleagues to feel supported, people to feel held and to not feel alone. And we can be present in person, but also I think what coronavirus has taught us is that we can also be present in other ways. We can be present at the end of the phone, we can be present on Zoom, we can be present in our connection with the family. I think another thing that's really important, again, that has come across to me through the reflections that people have shared today, is never underestimate the therapeutic value of just being with someone, or sitting in silence, of holding a hand, maybe of smoothing a blanket or filling a water jug. It's often these very small acts of kindness that have the biggest impact for families. I think, coronavirus, the pandemic, has also been a time where people have been much more emotional. Most of us have been worried about someone, perhaps older relatives, friends, partners who are vulnerable. Some of us have children, and some of our children have found it very frightening or confusing, not understood why they're off school, or, for a while, one of my children was scared of going out. Some of us as professionals have felt very exposed and frightened coming to work. I know at the beginning of the pandemic, I felt my father had just died, not of coronavirus. And I think that heightened my vulnerability coming back to work. And my husband has chronic health problems. I was really very worried, not about myself, but about what I was exposing my family to. Needless to say, we all got coronavirus and we were all actually fine. But it was, a frightening time for a lot of people. And another thing that has affected us during coronavirus is, for a lot of us, our usual support networks haven't been available. We haven't been able to do those things we would normally do to relax and to escape from work. For some of us, we've been working at home, and work has entered our home in a way it never has before. I've worked at home quite a bit, but there were some definite new experiences for me. The funeral of one of my patients, something that's usually safely contained in my working environment, was live streamed into my bedroom. It was a very, very different experience. Normally, I have a physical distance between going to a child's funeral and then being at home, whereas this one just came right into my home, and you know, the most private part of my home. It's the quietest place in the house, which is why I have to be in my bedroom. You know, you're all seeing me in my bedroom. Work has come home in a way it never has before. And in palliative care, it's a very emotional work that has, you know, I would use the word almost invaded my bedroom. We've also seen more distress than usual amongst the families. Our families don't have their support networks. You know, this is one of the things, I think that everyone reflected on, particularly Zoe, was saying we've seen more acute levels of distress, heightened feelings of guilt, of anger, of loss and of conflict. And all of us at Great Ormond Street are caring for seriously ill children at a time when we're much more emotionally vulnerable than perhaps we have been in the past. So I really just wanted to end by saying that I think one of the most important things for us all to remember is that as professionals, the ability to experience this real, raw human emotion is a strength, not a weakness. We often think that we shouldn't experience things. We should be able to look after a dying child and be absolutely fine and not feel sad. But it's a strength to be able to feel those emotions. But the important thing is that we all need support and recovery activities so that we're not overwhelmed by those emotions. And I think recovery activities need to be things that are healing, and they need to be things that we timetable into our lives. And they're really, really important, and that's why we need to timetable them in. So for me, it's swimming. And it's interesting, I was reflecting on what Dorothy said. I think water, either a pond or a pool, is definitely my sacred space. And I didn't know what Dorothy was going to say, but funnily enough, when I was swimming yesterday, I was feeling all relaxed and thinking, gosh, this must be like, a baptism when you're immersed in water. So I can definitely relate to needing those sacred spaces. For me, sometimes it's iced cold water that I need to be in because I really need to feel alive, and other times it needs to be warm water so that I can feel soothed and relaxed. So I have different pools for different occasions. But for me, it's a healing activity, and it's a healing activity that's important as eating or as brushing my teeth. And one thing that I think we should all encourage amongst each other is that we all think about what our healing activities are and actually make sure we have healing activities and do them routinely. And I think it's really, really important that we do them routinely and that we see them as a necessity and not as a luxury. They're things we shouldn't feel guilty about doing. They're time that we need, and they're time that we need so that we're not overwhelmed by the work that we do, and so that we can carry on doing the work that we do. So I think we're probably going to end there, and we're open for any questions if people have any.
Thank you, Finn. So can all the panels turn on their videos? Thank you so much from all 6. Excellent, moving presentation from palliative care team. I got a live WhatsApp feedback on how much they have been touched by. It's really, deep reflection from each aspect of clinical areas in palliative care team. So we do have a couple of questions on Slido. So I will start with the first one. So thank you for the amazing session. What are the positive things you learned from COVID-19 influence on the palliative care delivery?
Well, I can always answer something, but so can other people. I think for me, one of the real positives has actually been finding ways of working from home and for it actually to work. And I have also found that sort of a personal development thing. I mean, we do a lot of working from working in family homes and going out to visit them. And at the beginning of the pandemic, we had to really cut back on what we were doing. And I thought I would find that very difficult. And I've actually found that you can develop a good working relationship with parents over the telephone. You don't necessarily have to see them. And actually, I can support more families in a day by Zoom and by telephone than I can if I'm doing home visits. So I've learned that I don't always need a home visit, and I hope to do a lot more remote working using video. Also, families like it. so many families say they come all the way to Gosh, they take their child out of school, a child with multiple disabilities perhaps, they come all the way to Gosh for an appointment, and actually sometimes the child isn't even examined because you don't need to examine the child in that appointment, or sometimes they feel it wasn't really necessary for the child to be examined. A lot of parents have said they would much rather, going forward, have the option of home consultations by video. So I think that's something to build on, definitely.
And I would echo that. I think parents having choice around how they see and meet with us, and we've do a combination of Zoom remote kind of sessions with families from a psychology perspective, and also meet them on the ward or bring them in for outpatient appointments. But I think there was something, particularly if I think about the families that are long stay patients on the ward, or in isolation, so the children are having transplant, for example, where there's high risk to them in terms of infection generally, limiting, being able to kind of form relationships and offer remote sessions has been really helpful for people, for parents to have the choice. Also being able to have conversations that are difficult away from their child's bedside, because usually we would see families by the bedside, and then children are part of that conversation. Of course, that sometimes can be really helpful, but parents having a separate space and that being by choice has been really positive in terms of the development. I would also say the kind of, I mentioned it in my bit, but the being able to offer debriefs remotely, and sometimes we do that in a mixed forum. Sometimes there's some members of staff that are face to face in the room with us, and other people that are joining via Zoom, but being able to have two facilitators, one who can hold the psychological safety on Zoom and one who can do that in the room, that's a nice combination. So I think just the creativity that comes with being able to use technology slightly differently to deliver care.
Bhumik would like to add something.
Sorry, I just wanted to say that I think two positives for me have been, one, the first one is that we all know the NHS is a massive, cumbersome juggernaut. It doesn't do change very well, very quickly at all. But the one thing that COVID has shown is that we can change when we have to, and we can change to make very, very effective and meaningful changes and to the better of patient care. So that was one huge thing, that actually as an institution, we have the capability and the willingness to change. But also the fact, the joint learning. We don't often learn from each other, not just, I don't mean within Great Windsor, I mean nationally, learn from each other well. And paediatrics, learning from adults and adult learning from paediatrics often doesn't work very well. But again, we've shown that we can learn from each other and have shared good ideas and good innovations through this whole period. And I think it's a bit like the space race. I think when we reflect over the last 6 months, we'll probably find that we've had more innovation in the last 6 months than we've seen in the last 2 decades in terms of innovation and change.
Pressure-induced innovation and accept technology incorporated into NHS, and like us, grand round on Zoom, and the people at home able to attend rather than the Euro format. So if no further input, I think Jonathan going to ask the second question.
Maybe I'll mute myself. Yeah, that's the thing. I think that, I mean, we've talked a lot about well-being and looking after ourselves during COVID. I mean, you guys have really been, you know, at the sharp end dealing with people's grief and patients, from the patients and the family point of view. I mean, what's your advice for staff to help sort of recover this emotionally draining time, bearing in mind we are now being all asked to go back to deliver a full clinical service, so we're going to get busier and busier?
One of my favourite writers is an Irish chap, John Donahue, and he has this quote that I love, which is, "Be excessively gentle with yourself." And I think there are just times I've had to really talk to myself about this, that stop beating yourself up for all that hasn't been done, and just take half an hour. Just be excessively gentle with yourself, because then you can renew that energy that is depleted. I loved Finn's quote, "Different pools for different occasions." I think that could be a podcast title, Finn. But somehow we do need to be really cognizant of our own needs, and that's not selfish. It's just good self-care. You know, during the height of the lockdown, I walked 5 kilometres every afternoon about 4:30, 5 o'clock, and just kind of let go of all that I'd seen and heard and been part of in the day. And I normally wouldn't take that time to do that, but it really, really helped me keep on track.
That's good advice. Thank you very much.
So I think there's the next question is, so it's a question for Dorothy. Do you think a family would benefit from mourning at a memorial field months after the deaths? I think you briefly mentioned slightly.
Yeah, I think some families will and some families won't. Again, at the height of the lockdown, I saw that Charlie Mackesy drawing one day. I don't know if you can picture it, or if somebody clever can find it. It's a heart and two people hugging, and it just says one day. And I think for all of us who experience sadness or loss in lockdown, and for the families we support, there was that the added pain of not being able to grieve with, in that very physical, visceral way, grieve with people we love and care for. And I think some families need that hope that one day they will be able to do that in some way. But I think for some families, they will feel we've done that stage now. Interestingly, we've heard from some families that a very small funeral, which at the very thought of it, when funerals could be no more than 10 people, it felt really traumatic. On the day, quite a lot of families have been reflecting back that actually they felt they didn't need to put on a front with their grief. They didn't need to filter it. They could just allow the intimacy of that to be a gift, not a burden, which I hadn't even imagined would be the case. So I think the answer is some will feel they want to, but not all.
Okay, thanks. And I think we've got time for one last question from Slido, and I think this is the question that's been alluded to before: is that what could we do differently? I mean, how have we learned from COVID, and what could we do differently as an organisation if there is a second wave? If we have to go back into it all over again? Anybody? Maybe look after ourselves a bit better.
Gosh, silence. Go on, Zoe. You go. You go.
No, go. I was going to say, I think it's really difficult, isn't it? We're talking just in relation to the impact of the families with the children who are dying, and I feel like that's the bit that we can speak most to. I feel, I mean, we've talked a bit about the impact of the one carer policy. I know it's controversial and tricky, but I think there's something about us weighing or being more overt about the psychological impact that has on our families, and how we balance that with the risk of physical harm to our families and our staff members. I know that's an incredibly tricky one, but the whether or not we can think a bit about how we manage, if we need to restrict parents coming into hospital again, how we do that with some consistency, or how we think through that sort of not end of life in the last few days, but in that kind of period of time leading up to it. But that would require us, I think, organisationally, to acknowledge that we can't save all children all of the time, and so get to thinking about palliative care and the end of life quicker. And I think that's incredibly difficult. I don't think there's an easy answer to that, but I'm just thinking about that sort of few weeks leading up to a child's death, whether or not there's ways in which we can be flexing at that stage. I don't know. I don't know if there's other stuff around the mortuary and visiting the mortuary, if Rachel wants to say anything about that, but I think that also had a big impact just in terms of how parents manage that separation and the kind of severance of the attachment, and how we know that actually when parents come to that in their own time, that's better for their psychological well-being than it is to have that kind of enforced in a way. I don't know, I don't know if that's a very
Yeah, I mean, I suppose we have the benefit, and this will apply to other specialities, of knowing a little bit more about what to expect. So in terms of staff support and family support, I think, if we were to go into that situation again, rather than responding to things that we didn't necessarily expect, we'd be able to plan in advance. And I think, certainly for me, I became much more aware of the need for for me to have somebody to not just debrief with, but have that kind of pre-brief if I knew I was going into a really difficult situation that I didn't necessarily feel prepared for, to make sure that I had somebody that I could just pause for a minute to talk. Sometimes I think, particularly in that kind of crisis situation, it's so easy for us to get into crisis kind of mental mode and dive straight in, because it all feels like an emergency. But actually I learned to really think, what are my aims going into this? What do I want to achieve? Like, how do I want to help people? And actually break it down, and it all became much simpler then. Actually, it was like we've talked about, it was about, I just want to show kindness and compassion in this awful situation. But in order to do that, I know I need to be kind and compassionate to myself, and actually sometimes I need someone to help me do that.
Okay, thanks. I think that's fantastic. We've come to the end, I'm afraid. I'll hand over to Sherry to close.
Yeah. Thank you, everyone, to join us with this excellent, long-needed session from palliative care team. So our next grand round will be from pain team on the 23rd of October. Sorry, September. I'm moving too far. 23rd of September. See you then. Bye.